So, a few years ago, Rinaldo Bellomo and myself put together the concept of giving most to our patients, multiple organ support therapy. And extracorporeal organ support is the portion of most that can be achieved with extracorporeal therapies. You have seen the evolution through the history of the different machines and the different technologies. And today, the last generation of machines represent a real platform enabling us to perform different type of therapies and also simplifying our task to perform our therapies. Different techniques can be actually performed from hemofiltration to hemodiafiltration, dialysis, coupled plasma filtration, adsorption. I think one of the important aspects is that we can add technologies to our extracorporeal circuit in order to achieve different tasks that are required in our complex patients. And we have recently published in JAMA this kind of viewpoint where lung, heart, kidney, and liver can actually be supported at different level, escalating and de-escalating therapy depending on the patient requirement. We have also seen that multiple organ support therapy may be the therapy indicated in patients in which, in spite of one organ initiating the syndrome, there might be several other organs involved in the syndrome with what we call the organ crosstalk. And today, the possibility to adjust the circuit from ultrafiltration to dialysis, plasma filtration, plasma exchange, hemoperfusion, albumin dialysis, CPFA, VV and VA ECMO and ECOR, allow us to perform this new type of support. We know that the organ crosstalk may actually occur at the systemic level, at the organ level, at the tissue level, and at the molecular and cellular level. This is important when you try to plan a support for this function of any of this situation. Devices are designed to achieve a simplified approach to extracorporeal organ support, and you may need to work on fluid balance control system, new membranes, new sorbent devices, maybe wearable devices or population-specific therapies. I think that we are more and more looking into integration of different hardware and monitoring system, possibly having antithrombogenic circuit or antimicrobial surfaces, self-adjusting temperature system, minimum storage volume, and possible biodegradable with minimal wasting, making the circuit environmentally friendly. For example, we have seen how much interesting can be to combine bioimpedance that describe the overall status of hydration in a patient with blood volume variation during extracorporeal therapy. And when you combine the two, you can actually identify an overhydrated patient that still may crash during ultrafiltration because you are removing too fast. On the other hand, once you optimize the speed of fluid removal, bioimpedance can tell you at the right moment when you are removing too much, and so the patient can crash again for a different perspective. Now, we have information that when different organs are interacting, they may actually have an impact on kidney function and cause acute kidney injury, but these arrows are bidirectional, and AKI may actually have an impact on cardiorenal, on lung-kidney interaction, hepatorenal syndrome, sepsis, and so on. On the other hand, we know that most therapies can actually, like mechanical ventilation, ECMO or ECOR, and extracorporeal liver support, may have an impact on kidney function. At the same time, a patient with AKI may be requiring different modalities of therapy. And this, finally, is a condition where different type of extracorporeal therapies may interact with the renal replacement therapy. At the same time, renal replacement therapy may actually affect different type of extracorporeal support modalities. This paper is going to be published very soon in Intensive Care Medicine. So this is something that has been discussed with the ADKI group, especially in light of the idea of providing precision CRRT, and the future of extracorporeal support system is based substantially on several different aspects, including the multidisciplinary approach to critical illness, close attention to native organ crosstalk, but also to artificial organ crosstalk, the danger and threats of using adoptive technology, the need to harmonize nomenclature, and the integration of extracorporeal support techniques and hardware. First of all, the multidisciplinary approach to critical illness depends on the fact that we may need specific competence to treat the different organs that present dysfunction, even in presence of a complex syndrome like cardiorenal or hepatorenal syndrome. This is what we call a multidisciplinary approach, but this should take care of what we call native organ crosstalk. One organ dysfunctioning may have different situation when another organ is involved in the syndrome. So we need to pay attention to this, and we need to have specific competencies talking to each other. We need also doctor crosstalk. Close attention to artificial organ crosstalk. We have to learn a new physiology, because these are physiology of non-native organ, artificial organs. And when they interact one to another, like VA ECMO together with the CRRT and vice versa, I think we need to learn the physiology of this new kind of interaction. Several times in the attempt to support liver or lung or the heart or the kidney, we may use different technologies. And this leads to different devices and circuits that are not talking one to each other, and we have the risk to multiply the errors. And this we have already learned when we started using CRRT with non-integrated machines like fluid balancing systems and blood pumps and so on. We need to speak the same language. Nomenclature harmonization is important. We have signed a kind of alliance between professionals and companies in order to try to use the same terminology, avoiding possible mistakes of or even lack of comprehension when data are recorded in electronic medical records. The other aspect relates to escalation and de-escalation of treatment complexity. Life, especially I'm telling this for our intensive care friends, life exists before intensive care and hopefully exists after intensive care. So when you discharge a patient, we still have to take care of that patient, and in some cases we need to de-escalate therapy, but they are not ready to be discharged from hospital, so we need to move them from continuous to intermittent therapy, non-invasive ventilation, and so on and so on. So there is a need to integrate the hardware and the techniques, and I think that there is nothing like this area of critical illness to enable us to specifically interact with different disciplines. Let me make an example of the sepsis condition. If we agree that there is a cascade of events that goes from infection and dissemination of LPS and activation of the different pathways with recognition of LPS and activation of endothelium and humoral and cellular effectors affecting microcirculation and finally organ dysfunction, we may somehow figure out that multiple organ support therapy should tackle every step of the sepsis cascade. So infection, for example, should probably considered as a target for surge control, maybe endotoxin removal, and it is quite specific. Drugs may be somehow important across the whole story of sepsis. But in the phase of immunodysregulation, immunomodulation and cytokine removal may become a very important approach. And finally, if you have organ damage, organ support may require a specific action. So let's imagine, for example, an integrated approach to sepsis that may explain why in several trials one single intervention may fail. Because you may need at the beginning endotoxin removal, and we have techniques for this. We may need to remove cytokines, and we have seen that this is important. By the way, remember that sepsis is not just any pro-inflammatory disorder, it's an immunodysregulation, is an altered immune response. So you may need to regulate excessive hyperinflammation, but also immunoparalysis, what we call immunoderangement. You need to achieve a kind of elimination of the peaks of pro and anti-inflammatory mediators, which was what we proposed several years ago with the peak concentration hypothesis. And finally, we need to support different organs with the different extracorporeal circuit. So just to conclude my very, very simple and quick talk, from the native organ interaction, we have now to move and better understand what is the crosstalk between the different extracorporeal circuit that we are using for ECOS. We have recently proposed in a kind of viewpoint that we wrote about the concept of moving from multiple organ support therapy to extracorporeal organ support, the idea that we need probably a next generation of machines that are platforms capable of installing different components, different techniques and operation of making multiple extracorporeal therapies, also able to escalate or de-escalate the complexity and the severity of the therapy. With this, I thank you very much. Maybe next year we will have a discussion on new technologies that are related to this approach. Thank you very much.